Right. So we have to put in a lot of factors when we decide about treatment. We look at the functional status of the patient, how much damage there is in the kidneys. Is it recoverable? We frequently use a kidney biopsy to determine that. So there's a lot of active disease and very little what we call scarring or fibrosis. Then we say, let's hit hard so that we can get back function. Whereas someone is weak and frail and there's a lot of damage to the kidney, chance of recovery is not high. We say, let's not push our envelope too hard here, because you may actually cause damage. And understanding the drugs is the critical part. Traditional treatments have been using medications like very high doses of corticosteroids and drugs in small doses that are used for treating cancers. They're quite powerful. They have fairly significant side effects, and they're not always successful. So the move is to try to develop more specific, what we call targeted therapy against processes that causes damage to the kidney. And these are like, the analogy is like taking a sniper bullet versus a bazooka, because what we have right now is a bazooka form of treatment. The holy grail of lupus treatment is what we call personalized medicines, where we take a patient's clinical features, genetic profile, and the abnormal proteins that they produce, and then customize the therapy for them. It's not quite reached prime time because there's still a lot of discovery being done, but what we have is a whole array of very specific targeted therapy that's being tested. Unfortunately, not all of them have shown to be positive, but there are clearly a couple of newer therapies that are being looked at, which holds promise, and the final results are still pending on those studies. So hepatitis C has undergone a sea change. Now, it began with the discovery of drugs that that do not use interferon, which used to be the mainstay of especially hepatitis C treatment. So now there are relatively non-toxic drugs that, when used in combination, can almost guarantee, I'm going to use the word strongly, over 90% success rate with fairly minimal side effects. So the point is that it's not yet been tested in patients with kidney disease, but there are at least 2 clinical trials that I'm aware of where these drugs are going to be tested, and it's going to offer patients the chance of actually getting rid of the virus permanently. Right, that's a little more tricky. If you have a combo HIV and Hep C, the drugs are somewhat similar, and the exact cocktail has not been figured out, but it's highly likely that the same drugs that are very successful in the non-HIV patient are going to be useful in HIV-infected patients as well. 20 years ago, HIV was a fatal disease, and we used to lose a lot of patients from kidney disease from HIV, and now patients are living longer. They do have metabolic complications from drugs and from other diseases, but there's a chance of a fairly good life span and even quality of life. And now with these newer drugs in Hep C, whereas patients would see some damage, say 20, 30, 40 years down the line, that's hopefully going to be limited as well. With respect to a kidney transplant patient who has hepatitis C, it's a complicated situation. And this is the place where we are really hoping that these new drugs can be tested, because we cannot give them interferon. From the point of view of rejection is very high in such patients. So there's a good chance that we can actually cure the patient with these newer drugs, but it does need to be tested, especially for safety.